Morning, sir. Morning, everybody. At the outset, I would like to thank the CSI for giving me the opportunity to speak on this topic. My topic is approach to patient with a peripheral ulcerative keratitis. This is a special group of diseases which has certain features. First, it's an ulcerative inflammation with a gutter in the periphery of the cornea with margins. You can see this white margin laden with WBCs and the inflammation of the juxtalimbal conjunctiva. It is usually associated with local or systemic autoimmune diseases. Adjacent scleral inflammation is present generally, and 30% of cases is bilateral. Clinical features: dry, gritty, foreign body sensations associated with tearing, redness, photophobia, blurred vision due to high astigmatism associated with photophobia, and intermittent flare-ups. The associated diseases may be long-standing rheumatoid arthritis being the most common. Other diseases like SLE, Wegener's granulomatosis, relapsing chondritis, polychondritis, polyarteritis nodosa and its variants, polyangiitis and Churg-Strauss syndrome. Other diseases like hepatitis and also been noted. Complications, it may lead to, besides the systemic complications, it may lead to perforation, infections, and visual losses. The examination, painstakingly thorough examination is the key for diagnosis and further management. Thorough history taking, ocular, medical, and family history. Examinations, BCVA, K1, K2, slit lamp, etc., and imaging, all sorts of imagings available to you. And the blood investigations, the TLC, the ESR, C-reactive proteins, RF, Montox, and the Kenka-Penka tests. Management, the goal of the management is threefold, is three-pronged approach. First, we have to treat the etiopathogenesis and of the etiopathogenesis and managing with the help of immunologists or physicians. Secondly, dealing with the juxtalimbal conjunctival inflammation by cauterization and peritomy of the juxtalimbal vessels, blocking further ingress of the inflammatory cells. And the last one is facilitating the epithelium wound healing by filling the gutters, that is, or the ulceration, with the help of biological fillers. Now, the biological fillers which are available to us are the amniotic membrane, which may be used in multilayer. Secondly, some people have used stromal tissue with the help of biological glues, fibrin glues. And the third one, which myself has developed, this is a piece of Bowman membrane which may be tucked in by creating a recess around the margins of the wound. These are a few results. There you can see Bowman membrane put over here with the help of a glue, and the epithelium has covered it nicely, and you can see the juxtalimbal vessels have recessed. This is about a month-old inflammation, PUK, with a perforation you can see here. This is another one, a very small one, but this is a Bowman's patch. This is a very old one, so around 8 months old. You can see here, these are the margins of the Bowman's membrane, which has been tucked in, and now it's not barely visible. And it has obviated the need of a therapeutic PK. And the vision is around 612. This is another one old with a large perforation over here. Post-operative treatments according to the original disease that will go on with the help of immunologists and physicians. Oral and topical steroids, tapering in 6 weeks, and preservative-free antibiotics and plenty of lubricants as and when required. So conclusion, early diagnosis and painstaking thorough investigations are the key for preventing sight-threatening complications of PUK. And Bowman's membrane tuck-in procedure is a simple and promising technique for filling and healing the gutter and controls further loss and avoids larger procedures. Thank you.
Thank you, Dr. Dhanveer. Samar has a question.
So how do you take the moments, only moments?
From the donor?
Yes, yes.
First of all, sir, we mount it on the corneal scleroderm is mounted on the artificial chamber.
Yeah.
Then the epithelium is debrided. Then we put some trypan blue just to stain that the Bowman's membrane. Then the intrastroma, the stroma is then emphysema is created so as to separate the stroma from the Bowman's or to loosen up that Bowman's from the stroma. Then after making a very small nick and creating with the help of a crescent, then stripping it like this.
Okay.
I've got a video, I will show it.
Okay.
Thank
Thank you.